All right. You can see my screen there, doctor?
Yep.
All right. All good. So, all right. Well, I'm Dr. Watts with Biogenetics. You can find us at biogenetics.com. And what we do is we serve providers that are in the functional medicine world. And so the business is probably 7 or 8 years old at this point. I've been with them for 4 years, consulting and teaching and all that kind of stuff, and able to help craft some of the products and get my fingers into all of that. So I appreciate the ability to have impact in patients' lives. And ultimately, that's what it's all about. So I'm a chiropractor by trade. And the only thing I've ever done is functional medicine. I've never had a neck and back clinic. So usually what happens is people say, well, what kind of doctor are you? I'm a chiropractor, but not that kind of chiropractor. Like everybody always wants you to look at their neck and stuff like that. And I say, well, you should probably find somebody else for that. So anyway, what we're going to do today is we're going to be talking about some of what I call the behind the scenes as it relates to thyroid mechanisms. And just want to give you the context to why we're going to be discussing this. Number one, if somebody makes it into a functional medicine practice and they're looking for help with thyroid, you have to think that they've already seen 6 or 7 other people. You have to think that they've already failed in the standard of care model, which means that there are one of 2 types of thyroid patients. One, where they get help in the standard of care with the thyroid hormone replacement, and 2, where the thyroid hormone replacement doesn't touch whatever their condition actually is. And so we're going to start looking at that today. So really what I want you to see is who's coming into your practice at this point in time with this style of care. Okay. It's not the person that's life is improved by thyroid medication. It's the person that's looking at you saying, somebody help me. My lab tests all look normal. The doctor is telling me I'm a crazy person and I can't lose weight. I can't sleep, can't go to the bathroom. I can't think straight. And ultimately they're knocking on your door. So we're going to start looking through that a little bit here. This is FDA information and it's disclaimer regarding supplementation as per usual. And my disclaimer is this, as per usual, is that this doesn't create a doctor-patient relationship between me and you, me and your patients, or biogenetics and you and biogenetics and your patients. And I'm not real worried about that here tonight, but just have to say it nonetheless. So, all right, this is a root and fruit graphic. This is how we explain functional medicine to patients. And if you don't have this graphic, all you have to do is email Kim at biogenetics.com and she'll send it to you. And I show this graphic to every single patient every single time. And I'm going to show you in the context of what we're working on today, how this comes about. So you have patients' lifestyle and environment, the trash that's in their lifestyle and environment, and the root structure. Forces their DNA to express chronic inflammatory patterns, which is giving them their lived experience up here. Right. So if they don't want high cholesterol or hypertension or fatigue, if they don't want to get beat up by thyroid conditions, or they don't want Hashimoto's destroying their life, ultimately it comes down to controlling chronic inflammation, which means that we have to introduce that old DNA into a lifestyle and environment that's more compatible with health and healing, something that's compatible with vitality. And ultimately that's what we're here to do. So this is the backdrop on what we're going to be working on tonight. And I thought about calling the presentation The Plight of the Thyroid. But ultimately what I want you to see is that the thyroid is the ultimate thermometer. The thyroid is the ultimate thermometer. And, in modern medicine today, in the standard of care, so many people are blaming the thermometer for how hot it is outside, or where Dr. Clearfield is right now, how cold it is outside. So many people are blaming the thermometer as if the thermometer is responsible for, the overall condition of the environment. And I think this is an important point that we can differentiate ourselves with as it comes to, functional care. And ultimately we're using the thermometer the right way. All right. We want to make sure that we understand that it's an indicator. It's hardly ever a driver. almost always an indicator. So we have 6 different things that we look at as it relates to functional health of the thyroid. And I listed them here for you. Obviously, we're not going to go through all 6 of them tonight. However, we are going to talk a little bit about autoimmunity, and we're going to talk about something that I call peripheral resistance. And the peripheral resistance might be new to some of you in the audience, but I guarantee you see it every day. And so hopefully can see the viewpoint as we go through the process here. So, all right. Just going to make sure that I have a chat window open here for us as well. And very good. All right. I got us organized now. If you have questions along the way, feel free to drop them in the chat box and we can discuss whatever you'd like to discuss. So, okay, so let's move on to the next piece of the puzzle here. We have our normal hypothalamus, anterior pituitary thyroid feedback loop that you would see. And the places that we're going to talk about tonight on where this can break down comically are right here. So there are a lot of different areas that we can see breaking down in this normal feedback loop where we have thyrotropin releasing hormone telling the pituitary to release thyroid stimulating hormone, and ultimately the thyroid producing T4 and 3. Now, the feedback loops are a common area that break down, but also the communication points between each section or each island are ultimately very sensitive. And I'm going to show you today how they break down, what they actually look like in the lab test, and how we're going to sort it out. What's the main mechanism? So you could have 2 of these red arrows being a problem for a patient, and the treatment plan is almost always the same, thyroid replacement. And ultimately, if we're bullying or covering up thyroid symptoms with thyroid replacement, it's hard to solve problems. Like if we push the beach ball underwater deep enough, you can't see the beach ball anymore. And oftentimes that's what's happening with thyroid hormone. So I do like using thyroid hormone with patients. I think it's necessary. I think it is a piece to the puzzle, but when it is the puzzle, there's nothing but frustration and a lot of anger actually for thyroid patients. And that's frustrating. So very important. As we look at this mechanism, I told you that thyroid is actually a thermometer, and the thyroid's a thermometer for metabolism. Okay? It's a metabolic driver. And the hormone that comes out of the thyroid is essentially your foot on the gas pedal of your car. All right. So I'm going to assume, Dr. Clearfield, you drive a Ferrari or something like that, living in Reno. Okay. And, you put your foot down on the gas pedal. You put your foot down on the gas pedal and you're obviously going to go faster. Okay. Well, when your brain decides to put its foot down on the gas pedal, it tells the thyroid to produce thyroid hormone. That thyroid hormone ends up, in circulation, and we have thyroid hormone hitting a receptor site here. And this receptor site is going to activate a whole mechanism of machinery inside of the cell that is going to take oxygen and glucose and it's going to mash them together faster. It's going to make ATP faster. You're going to make more CO2. You're going to exhale, and your metabolic rate is going to increase. So you eat food, you breathe in oxygen, you mash them together, get ATP, you exhale CO2, and that's happening at this site here. Now, as we age and as we have a pileup of toxic stress, right? It could be mechanical stress, it could be chemical stress, it could be psychological stress, right? If you're a news junkie. And what happens is we end up driving dysfunction at the mitochondria. Like 20% of your body weight is made up of these little boogers. That's a lot, 20%. And when they begin to dysfunction, it's not regional, right? It's usually systemic. And so when we have dysfunction head to toe, we end up creating a lot of this free radical damage, or reactive oxygen species. There's a paper I'm going to show you here in a little bit that talks about reactive oxygen species in a way that you don't really hear scientists talk about it very often. And so it's kind of encouraging to see that maybe people are starting to get this. So anyway, all of this is going on. And as this free radical damage piles up, the cell becomes dirty. It's like metabolic dust. As the cell becomes dirty on the inside of the cell is built for like 120 years, right? It's built for, you got to believe it's at least built for 100. And that cell's going to make decisions off of longevity. So when you have a cell that's dirty, is trying to live a long time, what's it to do? It's going to start creating a way that it can live longer, even if that means decreasing its output, decreasing its activity, maybe even decreasing its usefulness. And so you see these cells begin to downregulate function. Now, one of the mechanisms, which we're not really going to go into a lot this evening, would be something like insulin resistance, where the cell membrane starts to protect itself from glucose being able to cross this cell, right? So we're decreasing our ATP production through a protective mechanism called insulin resistance. Full-blown diabetes is a protective mechanism, and if we don't stop and ask, what's it protecting us from, then we're liable to participate with it, right? So it's protecting us from cell death. So this is one of those mechanisms. Another mechanism, another way that we could decrease the metabolic rate of this cell is by taking, T4, and instead of allowing it to be converted into T3, active thyroid hormone, we could maybe reverse that. We can call these two over here reverse T3, inactivating it. So now we're left with 50% of the metabolic driver that we had before. Right? So that would be a way that we could do it. Maybe if this cell, if enough of these cells are irritated enough, right, have been trying to protect themselves enough, we can create a little bit of inflammation. And the inflammation begins to turn off certain functions in our, HAT area here, our anterior pituitary axis. Okay. I mean, this is where we have to start thinking about the mechanisms from a practical standpoint, because a patient shows up, if they have high reverse T3, low normal T3, their TSH is normal, and the doctor's sitting there looking at them like, I don't know, you sound like a crazy person to me. It's really frustrating for them. Okay, so this is what's going on in the background, though. So I want to get that first and foremost. We have the metabolic dust, free radical damage piling up, and the body's left to try and sort it out. All right. So a couple of lab tests here that I just want to chuck out here for you, just so that we can see a couple of comparisons. So here you have a patient, thyroglobulin antibody showing up on, this was back in May of a couple of years ago, 631, and then they had an update a few months later, it's 558. So the thyroglobulin antibody is actually coming down, the autoimmune response. Okay, but we look at their TSH content, 0.075 down to 0.013, right? Neither of those are what I would consider to be appropriate. Okay, but the doctor giving the patient Armor here, a 68-year-old female, by the way, Armor. You see the T4 content go from 6 to 8, and you see the T3 content. This is a total T3 go from 92 up to 193. Okay, and so what basically is happening is the doctor is giving the medication based off of their symptomatic experience, even though the labs don't bear out a need for a thyroid medication. Okay, and so here's a question that I see that says, are we legally in trouble if we prescribe thyroid hormones and the levels are normal? Right. So for myself, I'll remove myself from the situation, because I'm in the natural care world. I can look at it and say, if I give somebody something that they don't need based off of a lab, I will certainly get in trouble. All right. So I don't know about medical board, et cetera, as far as that's concerned, but this would be the question. This is the standard of care right now. Patient has the symptoms, even though the lab is 0.075, they're still getting Armor. I think that is an interesting decision. Okay. But I think that is much more common than we could realize. So what's going to happen to the protective mechanism now? Right. So the patient goes from 92 here, 92 on the thyroid total T3, and we move it all the way up to something crazy in the 100 and change, almost 200 here. Right. So we are overwhelming this protective mechanism that's trying to downregulate thyroid function. I think it's an interesting concept. Okay. So that's patient number one. We'll probably come back to them a little bit later. Here we have a second case. This is a 75-year-old male on levothyroxine. Right. This is a case that actually went through a functional program, and we want to see a couple of pieces of this. I'm going to show you how this works as well. So you see their thyroglobulin antibody response go from 180 down to 58. Right. And that's a couple of months difference there. I believe it's in 90 days. Their TSH goes from 422 up to 7.4. Right, so we have the TSH getting fired up here. Meanwhile, the T4 has remained the same. Okay, that's interesting. The cholesterol content, marginal change. The triglyceride content, that's a pretty cool change. That's good for them. All right, so you see a difference here. This is a functional protocol versus the first patient, which was straight replacement based off of symptoms. All right. So we'll come back to these in a little bit, but I want to just put them out on the table so that we can rearrange them later as we go. So just note TSH rose with care, and it might be a little shocking, but I'm going to tell you that's the goal. Okay. That's the goal. You'll see why here in a little bit. We're not going to leave them there, obviously, but that's got to be the goal. So let's talk about autoimmunity here. And I have some storyboards that I made for you, and hopefully they make sense. And if they don't make sense, you have to let me know. So before we do that, I'm going to go through and just see if we can answer some of these questions here first and foremost. So, all right. It says, my patient, Miss Anna says, my patient, 84 years old, Hashimoto's for a long time, takes thyroxine 50 micrograms. All right. For about, is it 3 to 5 years or 35 years? She takes 4 milligrams LDN, low dose naltrexone, I'm assuming is what you're saying there, which is cool. Over 1,000 on the antibodies and over 900. So thyroglobulin antibodies over 1,000, TPO over 900. No significant improvement. Should she continue the low dose naltrexone? From a functional standpoint, as far as I'm concerned, I would wholeheartedly support that. And hopefully by the end of tonight, you have a couple of other buttons that you can push and see if we can get those antibody responses to chill out a little bit. So, all right. Thank you for the question. It says, Melvin here, do you give thyroid meds, even if the numbers are normal, but non-optimal levels? Ooh, good question. Being in the natural care world, I like to use what I would call fine tuning nutrients. So it'd be more of a natural thyroid replacement if you look at glandulars, et cetera. And so we'll use those to fine tune. Oftentimes you'll have an endocrinologist that they're like one or the other, where the endo will say, all right, here's what we're doing. You are in the lab range. So I'm going to see you in 6 months and see if you're out of the lab range. And then you have others that are more creative with the dosing strategies. So I don't know, what I would say is more appropriate there, but I will say this is that if you're letting your patients go 6 months without you checking on the function of their metabolism in the thyroid, if you're not looking at the thermometer, so to speak, I think that's too long. So thank you for the questions. Very good. All right. So here we have autoimmunity. We're going to be looking at these storyboards that I was talking about. So follow along here. Okay. This is a Hashimoto's mechanism. We're going to start in the bottom left-hand corner. And so I showed you a root and fruit earlier, the graphic of the tree. And here's a variation on that. Right. Here's a storyboard. These storyboards I teach my patients, because if my patients understand the storyboard, they're going to be able to teach their doctor. Okay. So here we have in the blue box, the patient's lifestyle and environment, right? Lifestyle and environment. And for some patients, they're living a lifestyle that's not necessarily compatible with health and healing. It's not necessarily compatible with optimal body weight, optimal emotional balance, you name it, right? So the other day I found a case that had some nickel exposure, lots of nickel actually. And do you know that nickel can drive severe allergy reactions when it comes to barrier systems? I think that's interesting. Mycotoxins, lipopolysaccharides being produced by the gram-negative bacteria in the gut. We had a blood sugar imbalance scenario, some systemic inflammation, and we found a lot of the things that are in their body that are not supposed to be on what we call a total tox panel from a company that is called Vibrant Wellness. I don't have any affiliation with them other than I think they have an amazing product that helps a lot of people. So anyway, so you have a lifestyle and environment that's combining with your DNA, which you're seeing here in green, and that's forcing the immune system into a reactionary state. Okay. So if your lifestyle is driving your DNA to express inflammatory patterns, your immune system is going to participate at some point. And at some point, we start making antibodies. And so here, this patient, since this is a Hashimoto's mechanism patient, they're making antibodies here, right? They're making antibodies here to thyroid peroxidase, maybe thyroid binding globulin. And you see the immune system, the red triangle, impacting the thyroid. Now, what's cool, you just had a question here where Melvin asks, what is the problem if the patient constantly needs to adjust their thyroid med? I'm going to show you right now, okay? So when the immune system attacks the thyroid, it is lymphocytic infiltration of that thyroid, and that thyroid gland goes through a very fine layer of apoptosis. And so the cells begin to die. And it's like a mean little kid with a needle walking up to you, and you're holding 100 water balloons. Okay, the little kid starts popping the water balloons. Is he destroying the hormone, the water in the balloon? No, he's destroying the balloon. The same way Hashimoto's is destroying the follicular cell of the thyroid, and we end up leaching excess thyroid hormone into the bloodstream. All right, so we're actually destroying the thyroid gland, which is what I hope you're seeing here. Looks like bullet holes in the thyroid. But what we actually are doing is we're having cell dying of the thyroid, apoptosis, and we're expelling that excess hormone that was already in the cell. We're expelling that into circulation. So now what you see here is you have a patient that has what they're leaching, these little blue triangles, what they're making, T4, a little T3, and the thyroid meds they're taking already, this large blue triangle on the bottom. You have 3 variables now in this patient's thyroid hormone story. Okay, so once the immune system is attacking, you are leaching. When you're leaching, that's excess hormone. So now we have more hormone than what would be normally produced by the thyroid. Right? Over time, it is a losing venture. Over time, the thyroid is going to be in a hypo state, as you would expect. Okay, but the point is that functionally speaking, right now, you have what you're leaching, what you're making, and what you're taking. That's going to give you your current TSH. So this patient shows up in your office, their TSH might be 4, okay, within the pathological laboratory range, right? And the reason is that they're on meds, they're still making thyroid hormone, and Hashimoto's is causing them to leach thyroid hormone into circulation. Okay, so this is stage 1. Okay, stage 1. So one of the things that I found in these cases here, so is Hashimoto's, hypothyroidism, depression, and anxiety. This is a sample of a total tox panel. This is what's in that blue box, by the way, right here. In the lifestyle and environment box is this trash. Verrucarin A is a mycotoxin associated with water-damaged food, wheat, oats, corn, barley, rice, rye, gluten-free grains, nuts and seeds, dried fruit, right? It's also associated with water-damaged buildings. So anybody that lives south of like Illinois, sorry, okay. Here we also have butylparaben. Parabens are carcinogenic. They usually come from personal care products like lotions and makeups and shampoos, some medications, antibacterial agents. Dimethyl phosphate is a farming chemical, right? It's an insecticide and or herbicide rather, and it's diabetogenic and it's obesogenic. Okay, so this patient's got weight gain along with their hypothyroidism, and we have some endocrine disruptors here. Glyphosate's an interesting one, and may or may not be carcinogenic or diabetogenic. It depends on whose propaganda you're reading, I guess, during the week. So we'll just leave that one alone. N-acetylcysteine here, NAPR. So this is N-acetylpropylcysteine, not the nutrient N-acetylcysteine. NAPR, this is carcinogenic. Right? So this is something that you're typically going to find from styrene products and the like. So anyway, interesting. So we see all of that in the root structure that's pouring gas on the fire of this immune system that's effectively, allowing these antibodies to eat the thyroid. Okay. So the patient goes through an intervention where we start getting rid of this trash. They start eating a more anti-inflammatory diet. Maybe they're moving more towards Mediterranean. Okay. Or if they're trying to avoid the verruca Rene, maybe they're moving more towards paleo. All right. Well, we end up with a different storyboard here. Okay. You can see the lifestyle and genetics down here, no longer pouring the same amount of fuel on the fire. Okay. They changed their lifestyle. So I got a big red line through the DNA here, right? We're not pouring gas on this fire to the same extent. The antibody response starts to slow down, okay, which means that the amount of thyroid hormone leaching out of the thyroid begins to slow down. Okay, so this is less thyroid hormone now, right? You still have what you're making, that didn't change. You still have what you're taking, doctor didn't change the amount of medication, right? But what changed was the amount of leaching you have. So we're leaching less thyroid hormone. Well, what's going to happen if we have less thyroid hormone overall? You're going to see the TSH go up. Okay. So in a functional style program, in a functional style setup here, I want to see the TSH go up in a Hashimoto's case. That means that you have effectively slowed down the immune system from destroying the thyroid. Okay. That's a pretty big deal. Now, if you go into the thyroid blogosphere out there right now and you read the comments that people are describing with their thyroid programming and their doctors, et cetera, you get somebody that raises their TSH and they are so upset. They think that the thyroid is even further damaged than what it was before, right? Because the providers don't understand this mechanism to be able to talk to the patient. They don't understand that the immune system is eating the thyroid, causing the leaching. Okay, so what most of the providers are doing out there is when they see this happening, they're just giving the patient stimulants, right? So what am I talking about? Selenium, iodine, and they're overwhelming the Hashimoto's patient with, trophic factors, trying to drive thyroid function. Well, if you have, 8 horses pulling a cart and 3 of them go away, you can still move at the same speed. The other horses just need to work harder. So when you're giving a patient, trophic factors here, like selenium and iodine, and you're whipping a thyroid to work harder, faster, stronger, and it's less of a thyroid already because it's been eaten by Hashimoto's, that's a losing game in the long run. It's a losing game. Those patients burn out over time. That thyroid will give up, okay? So when you have a Hashimoto's patient, what you want to see is a lifestyle intervention followed by an elevated TSH so that the gas has been stopped from being poured on the fire. Okay, so it's really cool. It's important, all right, but it's really cool. So you want to see that TSH come up. Obviously, you're not going to leave it there, okay? But we have to see that indicator first and foremost. Okay, now when we go through that process, we end up in this situation now where we need to be able to either supplement with glandular, okay, and there are different strategies with that. It's not as fine-tuned as you would like it to be. When you talk about dosing micrograms of levothyroxine or something like that, fine-tuned, right? Very, very targeted. And it's pretty amazing that you can dose a thyroid med and 8 out of 10 times you have the right dose. Okay. With supplements, it's a little bit less targeted. So somebody has a question here that says, is a glandular supplement almost as potent as a prescription thyroid? It depends on the patient's gut, unfortunately, and it depends on the dosing strategy that you're using with them. I use a very specific window of dosing and a very specific product. And it's not a biogenetics product, but I can tell you about it anyway, because I appreciate what they've done for the industry. It's a biotics research product, and it's called GTA Forte. All right, GTA Forte. So that is my glandular of choice that we use there. They have a couple of variations on it, but that's the one. Okay. So we'll tap that TSH back down a little bit with the glandulars, supporting the patient's metabolic health And as long as they're keeping the wheels on the blue box over here, we can continue to maintain. The question is, what happens when they trip and they fall and, they go to the birthday party and, well, 4 pieces of cake and 6 pieces of pizza later, where are we? We're back to this, right? And what happens is this TSH comes screaming down because they just poured gas on the fire and they exacerbated the leaching problem. Okay. So, and they know it. They know it. The brain fog fires up, joint pain comes back, the gut pains show up. It's kind of amazing. Okay. So that's a Hashimoto's mechanism. That's a style of autoimmunity that you're going to see. Okay. So a couple of other questions here. It says, what's the problem if the patient constantly needs to adjust their thyroid meds dosing? They have attack, relax, right? If you see the patient and they're under attack, your thyroid labs are looking pretty good. And you know what? The patient actually has a decent amount of energy. Is their T4 that's leaching into the bloodstream right now is pretty high. Okay. Pretty high. The immune system relaxes. TSH goes up. You see the patient and you're like, wow, I guess we got to adjust your thyroid meds again. So you move their TSH from 7 down to 3 is what you're trying to aim for. Okay. They come back and it's like that first patient at a 0.075. Well, that's problematic. Okay. So problematic. So it becomes this on again, off again relationship with thyroid hormone and Hashimoto's. So here's the point. You have to get rid of the aggressor. There's no progress for Hashimoto's patients, right? Even when you have thyroglobulin antibody over 1,000, doctor, or TPO antibodies over 900, where the lab stopped reading it at 900, it might be 10,000. Okay. Even when we see that, we want to make sure that we are getting the Hashimoto's thyroiditis to chill out through a lifestyle intervention. Okay. And usually that requires a reset. Okay. A reset. So I like Biogenetics does a 21-day metabolic reset. It's called the metabolic clearing protocol. And that's where we start with most new patients like this patient. If a patient walked in like this, we're definitely starting there. Okay. So once hypothyroid state is reached in Hashimoto's, can it still present in the future with hyperthyroid? Yes, it can. Yes, sir. So once that attack is back on, right? In the Midwest, it's corn-fed people in the Midwest, all right? So lots of mold on corn and, corn in the food, corn in the beverages, all of the stuff. So there's a lot of gas being poured on this fire, right? And when the patient is in hypothyroidism, they can present as hyper, yes. So speaking of hyperthyroidism, here's a Graves mechanism, okay? So Graves mechanism, where we have the pituitary no longer participating in TSH production, we have the immune system producing thyroid stimulating immunoglobulin. Right. So now you have, instead of Hashimoto's that's eating the thyroid, you have the immune system creating an immunoglobulin that's telling the thyroid to produce thyroid hormone, and you get a boatload of it down here. Okay. You get a boatload of it. My OCD needs to fix that typo there. So when you look at, thyroid stimulating immunoglobulin, and there's 6 different names for this protein here that's causing the thyroid to produce thyroid hormone without feedback loop interruption, by the way. So the feedback loop will not turn off this immune system because it's actually an inflammatory feedback loop. So same mechanism, though, we have to work on the lifestyle and environment and be able to get this to chill out, right? The other thing that you guys oftentimes are going to end up using is methimazole, and it works real well, right? It works real well, methimazole, but if left untouched, if you just give the patient methimazole and their lifestyle and environment don't change, those patients, epic symptoms, right? They end up coming to a functional provider, and the functional provider ends up just having to, working with a patient that's on methimazole, let me just put it this way, is like trying to get somebody to lose weight while they're eating an extra Papa John's pizza every day. Okay. So it is an effective medication, but it has broad reaching broad reaching effect. So it is amazing. So anyway, so same mechanism here though. The TSH is going to be held down by the methimazole. And to the extent that you can dampen the immune system's activity here with DNA in, driving these inflammatory reactions is really to the extent that these patients end up healing. It's pretty fun. So again, something that we appreciate with that. Now, the reason I want to talk about this is because the intervention, how do we work the intervention? Right? How do we handle that lifestyle reset? What it does is it jumpstarts your body's ability to start detoxing the root structure so that the DNA doesn't have to express these chronic inflammatory patterns over time. And, it's a pretty easy walkthrough. There's an ideal program as far as the eating that comes along with it. Easy to follow, recipe guidelines, supplement guidelines, etc. But basically, if we're going to fire up phase 1, 2, and 3 liver detoxification mechanisms and help this patient really have a reset, a metabolic reset, we want to see their TSH come up. So anyway, when you're looking at thyroid testing, remember to look at it as a thermometer rather than a driver. Your thermometer didn't make it 25 degrees out there today, Dr. Clearfield. It's the thermometer is just responding to the environment. And it's the same thing with the thyroid, okay? So develop a good relationship with the patient's thyroid and they will love you for it. All right, speaking of which, we get off the autoimmunity mechanism here where we're controlling the toxicity. We're controlling, obviously, the trophic factors with autoimmunity. You're giving the patient a quality dietary intervention, right? All of that's in the 21-day metabolic clearing protocol that I'm sure Kim is talking about in here. There you go. And it's the place that we start with most new patients, okay? Now, what I want to introduce to you over the rest of the time that we have here tonight is what I call peripheral resistance. And this is a concept that I've seen play out over the last decade of treating thyroid patients. Last year, I think I looked at over 3,000 cases of, functional cases like this, mostly metabolic cases, diabetes and hypothyroidism. Now, when we look at that many cases and that number of labs, what happens is you start to see patterns and you start putting the patterns in categories and the categories start, yielding strategy. So this is a strategy that has come with a lot of pain, okay? And so I want you to take this for what it's worth and you can decide to use it if you want or don't. Okay, it's up to you. So what we do, we have this thing called the CC service, the Clinical Consulting Service at Biogenetics. It's a free service. You send your toughest cases into the Biogenetics CC team, which I have trained, right? And they have also participated in thousands and thousands of cases. So it's me and another doctor, Dr. Peterson. And we'll read those screen capture video for you, right, with your intake paperwork. So you're showing what the patient's brief history looks like in their labs, what their goals are, and we'll tell you what to do, how to do it, how long it should take, what the patient should expect, and we'll send you that screen capture video through the HIPAA approved methods. You keep it. We want you to be the expert, right? And so you go and you deliver the information through your mouth to your patient and you change their world, okay? Last year we did a lot of cases, over 3,000 of them. And so if you haven't participated in that yet, it's a free service, right? All you got to do is just connect with Kim here. She's in the chat box and she can get that set up for you. All right. If you haven't done it with a patient yet, at least do it with yourself so you can see what we're talking about and, get on the right path. So changing lives is what this is about. So anyway, peripheral resistance. Here is a paper where we're talking about interaction of the endocrine system with the inflammation. And this one was back in 2014, as you can see here. It says it's a function of energy and volume regulation. Okay. Volume of what? Volume of inflammation. And so I want to see how the endocrine system responds to the weather, how the thermometer responds to the weather, how the endocrine system responds to the inflammatory buildup that's in the body. Okay. So it says here, I'm just going to read probably the first and last sentence for you. It says, during acute systemic infectious disease, precisely regulated release of energy-rich substrates and auxiliary elements such as calcium, phosphorus, etc., are highly important because the factors are needed by an energy-consuming immune system in a situation with little or no food/water intake. Okay, that's called sickness behavior. The sickness behavior is not only a patient's interaction with their environment, meaning, am I going to go eat food or not eat food? Sickness behavior is also a cellular function. Okay, also a cellular function. All right, so they go on to explain a few other things here. It says, in chronic inflammatory diseases, a preponderance of energy expenditure pathway is switched on. Right, sickness behavior is switched on, leading to typical hormonal changes such as insulin resistance, hypoandrogenemia. Right, don't we have that going on right now in the United States? Hypovitaminosis, mild hypercortisolemia, which these are all already impacting thyroid hormone, right? Increased activity of the sympathetic nervous system, like nobody has that going on right now, okay? And then we also have the renin, angiotensin, aldosterone system. Though necessary during acute inflammation in the context of systemic infection or trauma, these long-standing changes contribute to increased mortality in chronic inflammatory diseases. And I would submit to you that you're also seeing that in the context of thyroid disease. Okay, super interesting. So read that paper if you got a few minutes. Here we also have another paper that I want to talking about thyroid hormones, oxidative stress, and inflammation, the relationship between those three. It says the production of ROS, reactive oxygen species, and reactive nitrogen species occurs at a cellular level in response to metabolic overload caused by the overabundance of macronutrients. Pause. That is an assumption that back in 2016, I'm sure was okay to make. At this point in time, when we talk about overload, metabolic overload caused by an overabundance of macronutrients, they're saying this patient ate too many calories. What they're missing is the mitochondrial damage that's done through things like COVID, right? Somebody asked about COVID here. Okay, the inflammation associated with, any RSV situation, right? We're not just talking about you ate too much food. We're talking the calories are too high. We're talking about anything. It could be food. It could be an inflammatory driver because you got exposed to, too much barium during medical study, right? I think last time I was here, Dr. Clearfield was talking about gadolinium. Okay, and the point is that any of these things can drive mitochondrial dysfunction. It doesn't have to be food. So that is a representation here of their position, I guess. So anyway, in addition, mitochondrial dysfunction and endothelial reticulum stress contribute to adipose tissue metabolic derangement in obese patients. The ROS generation, further maintained by the inflammatory response in the adipose tissue itself, adipokines, etc., feeds the vicious cycle. The picture is worse in pre and post puberty children because puberty alters some of the inflammatory markers associated with endothelial dysfunction, right? You're also going to read about the thyroid in this study as well. So I thought this was super cool as they laid out reactive oxygen species and reactive nitrogen species in a way that lets you identify them almost as a personality, right? Something in the patient's body that is in too high of an abundance. It shouldn't be there. It's not like when you look at a thyroid patient that feels crazy because their TSH is up, it's down, it's up, it's down. The immune system is on again, off again, on again, off again. And they're living on this roller coaster of a TSH. They're talking to the doctor and the doctor's like, I don't know what to tell you, because the doctor's got 14 minutes and a prescription pad for levothyroxine. What happens is the patient's left out to figure out this information on their own, and they can't do it, right? They can't do it. So we end up in this position now, all right, where they feel like their dysfunction is a character trait, and it's not them, right? It's just the dysfunction at a mitochondrial level, right? It's not them. All right. So important. It's not a character trait. Sometimes you got to tell people that. All right. So same study here. Just a definition on the bottom, NTIS, non-thyroidal illness syndrome. This is where they have all of the symptomatic experience of hypothyroidism, but their lab tests look normal. Okay. So they go on to talk about here, oxidative stress can be related to hormonal derangement in a reciprocal way. Some hormones influence antioxidant levels, like thyroid hormone. More thyroid hormone drives more reactive oxygen species. Okay, if you want more antioxidants, you don't want to spend them as fast, you're going to end up having to decrease your thyroid hormone. On the other hand, oxidative stress can modify synthesis, activity, and metabolism of hormone themselves. Right? Therefore, oxidative stress is related to both systemic inflammation and hormonal derangement. So what's happening is the oxidative stress is the weather here. The thyroid is just the thermometer. Okay. The oxidative stress is our peripheral resistance. This is really cool. Reduced glutathione is an important cofactor of both antioxidant enzymes and deiodinases. All right, that would be one to underline. The enzymes responsible for the conversion of T4 into T3, right? Moreover, plasma levels of small antioxidant molecules like vitamin E and CoQ10, thyroid hormones are closely related to each other. I'll go further and say that as you see serum levels of CoQ10, vitamin E, glutathione declining, you are seeing the deiodinase activity move from the T4 to T3 conversion into the T4 to reverse T3 conversion, which is basically deactivating thyroid hormone as a protective mechanism to stave off apoptosis of those cells. All right. Both hyper and hypothyroidism have been shown to be associated with the oxidative stress model. In special cases are the autoimmune thyroiditis or the functional picture of low T3 syndrome. I about fell out of my chair when I read this the other day. Somebody in 2016, not in the functional medicine world, had to say functional picture of low T3 syndrome, observed in acute and chronic non-thyroidal illness syndrome. All right. So this is a viewpoint that if you understand the viewpoint, the peripheral resistance viewpoint to hypothyroidism, right, what you're left with is a gold mine for your patients. Okay. Your patients, let me just put it this way. You got 98% of thyroid population in the United States going in the wrong direction right now. At least 98%, right? And most of the 2% that are going in the right direction are going in the right direction and they have no idea why, right? They think they found the magic diet or whatever it is, right? And what I want you to see here is that it's based off of peripheral resistance. So if we cut a section of that graphic I showed you earlier where the pituitary is telling the telling the thyroid to produce thyroid hormone through TSH, okay, we have this feedback loop. Modern medicine says that inflammation shuts off the feedback loop mechanism between the thyroid hormone in circulation and the pituitary. Okay. So too much T4, you would expect the feedback loop to turn off, right? TSH goes down. What they're also saying is that inflammation will do the same thing, meaning poor old pituitary just getting victimized by inflammation there once again, instead of understanding that the pituitary is making an intelligent decision not to produce TSH because it doesn't want the rest of the cells in the body to go through mass apoptosis, right? Like the central nervous system is wired for 120. It is an amazing thing. It is amazing, right? It makes decisions passively, right, for longevity that most people would not make on their own, even if given the opportunity to do so. This is one of them. Systemic inflammation is peripheral resistance. Pituitary decreases metabolic push, TSH, okay, lifts its foot off the gas pedal in response to that peripheral inflammation, right? Inflammation suppresses pituitary function. That's one way of saying it. I'm telling you, this is the viewpoint that I want you to have. In the next 10 years, this is going to be a thyroid revolution, okay? your pituitary decides to decrease metabolic rate in response to peripheral resistance. All right, it's like this. This is, I don't know if this is actually, it looks like LA. So here we are. If you've ever been in LA traffic, you know what I'm talking about, okay? So here you're driving in traffic. Your car is willing to go 120 miles an hour, but you're stuck doing 12, okay? Is it the car's problem? No, there's resistance in front of it. Your environment is not going to allow you to go 120. Okay. But the moment that traffic opens up, the moment those cars step aside, what do? You push your foot to the floor and you are out of there. Enough of going 12 miles an hour in the left lane, right? That's what you do. And so the thing with the thyroid is it's going to do the same deal, right? When we have peripheral resistance, when we have this buildup of free radical damage inside of the cell, and because of the patient's genetics, they're not choosing insulin resistance. Their body is choosing thyroid dysfunction as a protective mechanism, right? I'm telling you, clean up the root structure. Go through a renovation of the patient's lifestyle. And if you don't want to do it, give them a plug and play protocol like the one from biogenetics, the 21-day protocol, right? And let us walk them through it for you, right? You don't even have to learn the protocol if you don't want to. We have assets in the cloud. That's me on camera telling the patient, hey, your doctor chose to use this. Here's why. Okay. It works real well. And I love introducing people to it because it is a massive step in the right direction. When we start cleaning out the trash in the root structure, forcing the DNA to produce patterns that are associated with vitality instead of chronic inflammation bulldozing the patient's life over and over. So anyway, I see that. If you have questions about it, make sure you're reaching out to Kim at biogenetics.com and she'll take care of you from there. What I want to do, Dr. Clearfield, you can come back on here if you would like, but what I want to do is go through the chat box and make sure I answered questions as it relates. So let's see, what else do we have here? What other lab panels do you request before treating thyroid? So we have a basic blood screen that we typically recommend for patients. And if you want information on that, you can get that through Kim. Sometimes doctors just send in a symptomatic questionnaire for the patient, their intake paperwork, and we'll piece it together that way too if we have to. But basically what we want to be able to do is have enough information to help the patient, but not so much that they drowned in inability to implement anything. So as that obviously is, you got to be sensitive to that as well. So
I just want to add something here. I'm Dr. Halasa, by the way, but nice presentation. I like everything you said, and it clicks very well with chronic disease prevention management, where we are restoring the redox and metabolic and immune and regenerative status of the patient. And what you're doing, you have this oxidative stress, which are those free radical generators, that the mold and toxins and the all this environmental toxins, which aggravate the immune system, and it's causing the shift possibly to Th17, Th1 in case of thyroiditis.
that's right.
But you also have the free radicals is shutting down the conversion of T4, T3. So if you add that to the equation here, I think when you start explaining how the free radicals increasing the inflammation is breaking down the thyroid, and thyroid is releasing T4, but the T4 is not converting to T3 because that's being blocked too by the oxidative stress. And so they're feeling, tired and fatigued, not because they don't have enough of T4, but because they don't convert into T3. And when you do the detoxing and you restore the metabolism and you detox the body and inflammation subsided, and then you have less T4, but also you have less T4, but those T4 is converting to T3 because that is the iodinase enzyme is now being functioning and it's converted to T3. Still, I think they feel better, not fatigue, because even if you have less T4, you still enough to convert to T3, and the T3 is giving you the functional effect of the thyroxine. Do you agree with me in that way?
Yes, sir. So the efficiency of that conversion definitely ramps up as you see the ROS content decreasing. So
Right.
very good.
Now
Yep.
the T3 is being converting good, which patients still feel better
Yeah.
than oxidative stress. Now, where is the mistake it happened? Is that a lot of doctors, they start giving thyroxine before they detox. So if you give that T4 and the patient is still toxic, right?
That's right.
What happened if you detox them? They may end up with becoming hyperthyroid, right?
That's correct. So
And
that's what I tell patients is like, don't take this the wrong way, but I want to see your TSH come up first. Okay. We won't leave
right,
it there, but I want to see the indicator. So that's right. Cool. What was the name of the outfit you were talking about there, doctor? You said there's some work you were doing with, and I didn't catch
yeah,
the.
we're trying to form what we call chronic disease prevention and management as a new medical specialty that's being entertained by American Medical Association.
Oh,
Uh,
cool.
they end up writing CDPM. They're trying to integrate it into medical school, into fellowship, residency. So we're trying to line up with AMA, because if you line up with AMA, you protect it. If
Yeah.
you,
Well, no kidding.
if,
That's amazing.
right, they integrate regenerative. All those are snake oil and all that stuff, and they're already flagging them. But if you use their terminology and with the things that they're being blessed, and you put it in your hat, then you kind of protect it. So it's just politics. It's just crazy, you know.
Yeah,
The way
that's cool.
because the people are running medicine, or the putting politics of the medicine and putting the regulatories, they're not doctors, right?
Right.
They are CEO, and all of them, they are influenced
Right.
by big pharma and the big money, and they're directing the whole protocols, and I think that's the reason. It's just the control is not medical doctors, and if there are medical doctors in the control, they already sold their souls to the big pharma. So that's what we are, I think, having in this health system we have in the United States.
So do you guys have like an organization or a website or anything like that up
Right,
yet?
it's CDPMS, chronic disease prevention by CDPM, chronic CDPMCS.com, CDPMCS.com. That's the website. And Dr. William is my friend, so
Yeah,
he's okay.
type it in the chat, Dr. Olaso, so everybody.
I
Yes,
will.
thank
I
you.
will save the
That'd be
chat.
great. Okay.
Right.
So cool. Very good. Let's see. We got a couple of other questions here. Thank you, by the way, for jumping in on that comment. I appreciate that. So, what else? Thank you guys for being here. This was great. So, what's my opinion of LDN 4 milligrams by Hashimoto's? So early on in my career, I would have said, I'm going to try to do everything as natural as I can. And I think that's partially because, you're a little zealous coming out of school, knowing what you know and all the stuff. And, but the other half of it, I think, is because I just didn't know. And, and I think it might have been unfair to patients as a younger provider to steer them clear of some of these interventions that are very gentle and help them with their quality of life drastically. And naltrexone happens to be one of those that I've seen change people's quality of life unbelievably, and without too much of a hindering side effects anywhere. So if my patients are looking at that, I will usually encourage them to go ahead and do that. And it puts us much further down the road than it would be otherwise. It's pretty awesome. So very helpful. So thank you for your question there. All right. Any other questions you guys would like to talk about? Anything at all? So if you have any information about the chronic Oh, it says here, do you check for chronic infections in relation to thyroid problems? Yes, that is a good question. Yep. Yes, we do. So
What about, are you dealing with any vaccine injury?
so that one is a touchy subject. I'll say outside of biogenetics, yes. Okay. So for myself, that is something that we've seen a lot of information around, and there's a lot of people that have interesting responses genetically right now to the different stressors in those environments. And so, you know, COVID, what was everybody doing during COVID? How do I boost my immune system, doctor? Right. And so everybody's taking all these Th1 stimulants thinking that there's no consequence for that. And 2 years later, autoimmunity is a dumpster fire in the United States right now. And then we also have the vaccination side effect of it. And, you know, so it's a brave new world out there. I'll just say that, I guess. So supplementally, we use a very similar approach to what I presented here with a 21-day metabolic clearing protocol for biogenetics. And, you know, if you have any of those cases where you're looking at them going, there's just something not right here, you know, send the case over to the CC team at Biogenetics, and, you know, and we'll look at it from our different viewpoint. And, you know, and through your viewpoint and our viewpoint, usually we come up with a strategy where we can take and push the patient case in the right direction for them. I mean, just the other day, there's a lady that was using tranquilizers because of pain. It was post-injection pain. I'll just call it injection pain. Okay. Post-injection pain, tranquilizers, laying in bed, and she can't get up. Right. And so she's sleeping until like 1 PM because of the hangover effect. And, you know, and we end up, you know, in a situation where she needs a lifestyle reset. She's got kids. She can't be sleeping until 1 o'clock every day. And so start moving the lady in the right direction, and she gets her life back. And, you know, she's on enough tranquilizers to put down a donkey, but, you know, it's, and it doesn't, it's not glamorous for people, but it made a difference for that lady, you know, where lifestyle reset, it's work, but sometimes it's worth it. So, all right, it says here, another question. What infections do you check? Very commonly, we're looking at EBV. Very commonly, we're looking at Lyme. Yeah, those are the big ones. Stool samples, I run those quite a bit. So looking for enteropathy, whatever might show up there. So Stefan
Have
said,
you fixed a tire before? Like, you know, you go to the whatever, the tire shop, right? And you have holes in your tires. You know how they fix it? They put in the water, right? And they see there's bubbles, right?
that's right.
I think it's a similar concept to doctors like yourself.
That's a really good
The
analogy.
biogenics, right? So you have a tire with many holes, and those conditions, mold and mechanical stress, gluten, all that, those are the holes, right?
Yeah,
And basically you are screening for all those holes, because those holes are leaking free radicals, pathological free radicals, and they're aggravating the inflammation and causing the resistance. And you are checking for all those holes to making sure, and you patch them all. So if you fix a couple of holes, right, and you say, well, you know what, I'll just do the food fasting and pesticide and whatever, and you still have for other holes, the tire will not inflate, and it will not be, you cannot drive it. So I think you are providing them with the protocols that helps to patch the holes, and it's all based on data collection of the data from the patients. And that's where AMA, American Medical Associations, they find out there is a problem there in the doctors collecting data. They're not comprehensively collecting the data that is related to those holes, right? And
that's right.
so they are very narrow-minded, or very tunnel vision in their specialty. And of course, if you're trying to manage, for example, Hashimoto thyroiditis by the mainstream medicine, I think Dr. William is agree with me. Actually, he has a very big lecture for that, and showing the difference between mainstream medicine and integrative doctors in managing Hashimoto thyroiditis. And those mainstream medicine, they don't care about the holes. They don't care about oxidative stress. In fact, oxidative stress, some of the mainstream doctors, they say it's a fantasy, right?
Yeah.
And they just give them the thyroxine and just go ahead, right? And then Dr. William say, no, it's not about giving the thyroxine. It's also about reducing the inflammation and all the causative, all the agents or all the leaking of those free radicals, those holes, and trying to screen them and find them and patch them so you can decrease the inflammation of thyroid. Because if you don't, chronic inflammation of thyroid can lead to cancer. But those mainstream medicine endocrinologists, they don't care about the inflammation, the progression of the inflammation. But that's where there's a good lecture from Dr. William showing the difference between management, and he did the same thing almost here, between the management of the mainstream medicine and integrative doctor, integrative approach, and how we are way more better than the mainstream medicine in managing diseases. Do you agree with me, Dr. William?
Yeah, well, of course, I'm the one who wrote it. So yes, of course. Yes. Yeah, I do. So,
so very good.
yeah.
I
It's a
appreciate you guys
yeah,
having
we
me on here tonight. This is
we
great.
appreciate having you, Dr. Watts, as always. And if you or Kim want to put a link or something that we can get our folks to get to your webinars on Friday.
Yeah, that's
there we
great.
go.
Can I ask one more question?
Sure, go ahead.
Cancer. What's your recommendation on diet with cancer patients, or do you outsource them out?
So I will say that I personally do not treat the cancer in the patient, but I'll treat the environment around them. Okay. So looking at this, based on context, let's say you have dietary recommendations. You have veganism on one side, all right, and then you have the I only eat ribeye on the other side. Okay. And if the patient's got cancer and they're already over here, they can't go any further in that direction. So you have to start looking for the carcinogenic exposure in that diet, right? Versus a patient who's like, hey, all I eat is ribeye and I have cancer. Well, I want to find out what carcinogenic exposure are you dealing with in this lifestyle. Now, the reality is most people are somewhere over here in the middle. And so what we want to do is actually look for the carcinogens that their body's exposed to. I will 100% of the time run tox panels on these patients. There's a company called Vibrant Wellness in California, Southern California, I believe. They have a product called a total tox panel that's going to screen for environmental toxicities. You're going to see mycotoxins, which is crazy town. And then you're also going to see heavy metals. And so this is just a urine sample. So you probably want to push or like prime the pump a little bit with some glutathione or something like that before you take the test. But running those on every single patient, every single time is what I recommend if they're coming in with, some life-altering condition or diagnosis like that. So you want to find it, because what happens is they end up exposing 6 or 7 different carcinogens, and you're like, well, where are you getting it? If you got foot pain and there's a rock in your shoe, nobody takes Advil, right? So what you want is to figure out, where are you getting that exposure? Where is this coming from? And, how can we facilitate removal of that trash? Number one, if your kidneys are expelling it. And then number two, how do we make sure that you stop taking that in? It's just a very small section of the population right now that looks for carcinogens when there's a cancer diagnosis present. So I would say you got to look from a diet perspective. I'm going to find something that's anti-inflammatory for them based off of their patterns and based off of what their, genetic predispositions look like. We do lots of HLA testing. If you're familiar with HLA DRDQ testing or any of the work by Dr. Richie Shoemaker, we do a lot of that. So, all right. I don't know if that answers your question or not, but.
No, that was perfect. Actually, completely agree.
All right. So what else do we have here? All right. So if you go in Vibrant Wellness, by the way, and you're looking for something called the total tox burden, it's going to be in a special section of their website that you only have access to after you get a login. And it's called discount panels, which is even better. All right. So you can find that there.
And,
All right.
okay, well, thank you, Dr. Watts. That was terrific as always. And I will be bugging you and Kim again in a few months for another helping here.
All right. All right. Well, thank you
never
guys.
get enough. Anybody else have any comments or questions?
There's one more comment or a question in the chat about dental and microbial health.
How important is dental and microbial health by thyroid? That is such a loaded question, but it is an important question. So I think it's extremely important. Okay. I don't want to get up in anybody's face about anything, but I will say that when you're looking at tox panels and you're seeing the signature of amalgams coming out of people's bodies, you got to start asking questions of where it's coming from. So one of my favorite doctors on the planet at Quicksilver Scientific, Dr. Shade, has a great, oh, did I do that or did you guys do that?
No, I think I did that.
Okay. I was like, I don't know what I just did. Sorry. Dr. Shade's got a great test. It's called the Mercury Tri test. And when you start seeing the signatures of dental amalgams, I mean, I don't know how you argue with that. And so I will constantly be pushing patients toward fixing that situation in a healthy way if we can. So
Yeah, if you have inflamed gut, inflamed gum, it's like inflamed gut. You know, you
Yes.
have leaking of free radicals and inflammation and toxins of the bacteria going into the body. And definitely that will aggravate any underlying inflammation. And any inflammation chronically can lead to cancer. So
yeah.
So it's the same concept like leaky gut.
And what the doc brings up here also, the oral microbiome is just such a huge opportunity for improvement for people, especially when they're dealing with conditions like psoriasis, when they're dealing with conditions like cognitive decline, even just addressing the oral microbiome. I was looking at a study the other day with psoriasis where they had 100% of patients have some level of improvement in their case, 100% of patients in the study, using something called Salivarius K12, which is like an old run-of-the-mill probiotic that costs $14. So it's an amazing thing. So anyway, that's right, Doc. So oral microbiome is a big deal too. All right.
Dr. Watts, if I could ask a question, this is Raphael here out
Hello.
of Nevada. And you mentioned with the tox panel, are you stating that someone should utilize glutathione before doing the panel, or should there be some level of disruption to get a better snapshot picture when
good
sending it for
question.
testing?
So one of the things that I found is that if I don't use glutathione, just a couple of days of glutathione before running the tox panel, is I'm relying on what their genetic ability to detox this trash exists as already. Okay. And for some people, they're sick, so you're going to find something. Right. But if we mobilize it, if we push, and then you catch all of that urine in a cup, you're going to see a dumpster fire, to use that term a second time. You're going to see a dumpster fire of a test. And I think it's important for people to know what they're dealing with. One of the other reasons why I've been pushing before we run that test is because if you run a follow-up test and you've been detoxing with a patient for 4 months, 6 months, whatever it might be, there's a strong likelihood that that test is going to look even more busy later on. So I think it's important just to get a clear picture there.
How much
Typically,
does how much does a test cost, Dr. Watts?
it depends on what their market rate is, but usually between $300 and $400. So if you buy the pieces individually, the 3 sectioned individually, I think it's like $700. So they give you a good deal.
So why are you doing it? I mean, it's better if the the data is being collected, and that would narrow down the lab that you require instead of just doing everything, right?
Yeah, so I'm not doing everything necessarily. I'm doing the 3 that I find to be pertinent for the autoimmune side of things. They have a pretty expansive lineup of tests that you could run. You could easily spend $5,000. So I don't know if that's what you're talking about or not, but
Oh,
that's
I'm talking about instead, it's economically, it's better if the patient you take the complete data from the patients. And when you take the data
Yeah.
from the patients, the comprehensive data, then you prioritize the lab that you're going to do instead of just doing everything. It's not
yes,
cost effective that way.
right,
And if it's everything is cashier, you need to make sure that you're not over load, in other words, burden the patients with the money.
right.
Of course, you can do all this, that tree that you have, those all lab tests, but that will
Oh
cost
yeah,
too much of money. But if you take a very nice, and that's why American Medical Association, they're focusing on taking history and making sure the patient's history is being taken right, so that you can narrow down the diagnosis and narrow down the management and treatment, and it will be more cost effective.
that's right. So nobody likes to spend $5,000 on testing and not have any money for groceries. So it's prohibitive to getting well. All right,
That's true. Okay.
cool.
All right, Dr. Watts, thank you so much. And Kim, thank you.
All right. I'll see you
and,
guys later. Thanks again.
Again, biogenetics is their company, and we'll get you their contact information if you need it. Next week, I've had a number of people tell me they'd like to speak next week and then drop out. So at this very moment as we're speaking, I don't have anybody. So if there's anybody here that wants to present anything, please let me know. Yes, thank you for a very informative presentation. Anybody has anything that they'd like to present, please let me know, because next week at the moment we're open.
I will present if you don't find anybody, but give
All
me
right.
last thing. Give me
I've
last
always
result.
got something if you need something. I got lots of lectures.
Here we go.
Okay.
You got him. So go with Stefan then.
Okay. All right. Otherwise, you guys are stuck with me. I have a lot of lectures too, but I get kind of tired of listening to myself. So
We haven't heard you in a while. Give us a good one.
well, let me think about it. Okay. So I'm doing AMMG in 3 weeks. I'm supposed to do thyroid and cortisol in 45 minutes. You think I can do it?
Yeah, the things that you're going to give to AMG, just give it to us.
So, okay. And then there's a case history too. So, okay. Well, I'll talk to you, Steve, and Dr. Halas. I'll give you a call too. Anybody else, has anything they'd like to present, please let me know. Okay. So yeah, Dr. Jacqueline says I can practice on you. Well, we've been doing that for the last 2.5 years. What do you think we've been doing here? So, John, you got anything for us?
All's good.
All is good. What's doing with Roatan and Honduras and your project?
It's all totally solid. Construction's coming along in Roatan in a big way. And everything's just totally positive. The new medical school that's being built, osteopathic medical school, is being built 30 minutes from me in West Virginia. And I think they have a lot of interest in the type of things we speak of. They think integrative medicine is the wave of the future. We're not used to hearing that, are we?
No, we were actually used to the opposite. So
Everything's going beautifully well. Thank you.
okay, good. Okay, anybody else have anything to add with new folks and
So,
old
John,
friends?
are you in
Good to see
Hawaii
you.
right now?
No, man, I'm a West Virginia hillbilly forever.
Or when are you going to Hawaii then?
When I get done with this group and all the good things we can do, the medical school officially opens in 2 years. And once we get that thing rolling, I'm going to connect them with you guys and you can take over.
There you go.
Yep.
Okay. So a couple of new faces and a couple of old friends. It's good to see you all. have a great holiday. It's, you know, a holiday for lots of us coming up. And we'll see you again next week, same time, same station. Right now, it'll be mystery hour. So, okay, so thank you and good night. See you next week, everybody.
Good night.
Good night.